all, Whitefield team giving me the opportunity to speak at this place, and it has been a little busy. Sorry, sir has been trying to sort of be very interactive, but I have voices from my side. So today I'll be covering subarachnoid hemorrhage. I think this is a topic of headache for everybody already. So I think everybody has faced this headache some point or the other. I think probably most of us have managed subarachnoid hemorrhage in some capacity at every center. Yeah. So yeah, we'll just get going from here. So here I'll be more, I'll be focused more on covering towards what we may want to focus towards exam. Okay, points that examiner may ask, the total number of steps and the kind of things that we have to cover in terms of presenting in an exam. Okay, the clinical management, it's very dynamic, but I will go ahead and present something that we can discuss towards exam point of view. Alright. So approach to patient with headache. I mean, yeah, that's going to be the topic here. So the headache per se is a big topic on its own, which probably at this point of time I'll focus on the most common cause of headache presenting to ICU, that is SAH. Okay. So we'll cover the diagnosis, classification, and management. So before getting down to business, I just want to give you this case scenario. Please pay attention to the words that I've highlighted in red. Okay. So we have a 65-year-old gentleman who complains of sudden severe headache. All of us have heard of sudden severe headache, nausea and vomiting. Alright. He also has a brief period of consciousness. So we will evolve this as we go ahead. But he is also a known case of diabetes, hypertension. He is a smoker since a very long time. He also has a regular alcohol intake. Okay. So on arrival to emergency, luckily he is opening his eyes. He is opening to verbal commands. He is oriented, but he is a little groggy. He is moving all his limbs on verbal commands. Okay. But he gives a history of headache few times in the last 1 week. Okay. So I hope things are very clear. We'll move forward with this in place. So as we can see, his BP is 190 by 90 and respiratory rate is 24 and RBA, the sugar is 230. We will come to know why we have mentioned all these things here. So when we had a patient with headache and he has this kind of history, the immediate feature is when he has been a little groggy. We have done an NCCT. The NCCT is showing SAH. The answer is very clear. But how to proceed from here and what all we have to cover in terms of assessing him and managing him is the important point. Alright. So the non-contrast CT of the head showed subarachnoid hemorrhage in the suprasellar and the quadrigeminal system. So patient was shifted to ICU for further management because he is a 65-year-old gentleman and he can always go back. Okay. So this is the classification of headache as given by the ICHD 2018. If you can see here, there are primary headaches, secondary headaches, and cranial neuropathies. This is an extensive topic on its own, which requires a separate class. The headache classification will stick to SAH today. Alright? Yeah. Going ahead with the topic per se. So subarachnoid hemorrhage is hemorrhage in the subarachnoid space. Of course, it's very self-explanatory. The primary site is in subarachnoid space. So I would just want to focus on one thing here. As we go ahead, I will come back to that. So other places are brain parenchyma, ventricular system, and subdural space. So these are the most common sites of intracranial secular aneurysms. Because we have already covered subarachnoid hemorrhage, most common times the spontaneous cause of subarachnoid hemorrhage will be aneurysmal related. Okay. So this is the most common sites for aneurysm that we can see here. So this is also important from exam point of view, that they may ask you to sort of comment on the circle of Willis and which are the most common points of aneurysmal SAH. So we can see that the anterior communicating artery is the highest. So this is the circle of Willis here, and you can see increasing basis how bad or worse the site of origin it can be. Okay. So here, coming to SAH per se, what happens in subarachnoid hemorrhage? The hemorrhage is happening in the subarachnoid space. It communicates and it is, between the subarachnoid and the pia mater, it is going all over the brain. Alright. So if you can see here, there is a hemorrhage because of an aneurysm. We are mostly covering towards aneurysm here. Alright. So it goes and distributes, the blood products are released into the subarachnoid space. Because subarachnoid space engulfs the brain as a whole, it causes a lot of secondary effect. The first thing that happens when the bleeding starts is called as early brain injury. What happens is, when there is a bleeding, So there is mechanical effect of the blood as well as there are chemical effects of the blood. So first, bleeding happens, the blood gets released here, there is early brain injury, there is microcirculatory constriction, microthrombosis, there are products of hemolysis being released there, and those always trigger oxidative stress and they cause stellar changes where it can actually lead into a cascade of systemic inflammatory response, probably sustained, confined to the brain. So what happens is, as it evolves, so going further and further and further, when the blood spreads and the reaction spreads in the brain, because it is a tight space, it is going to involve all the places of importance, especially the hypothalamus. When it tries to involve the hypothalamus, it is where all the parasympathetic and sympathetic system comes into picture, and that is where we see systemic complications that is secondary to the hyperactivity of the parasympathetic and sympathetic systems. Alright. So causes, what are the most common causes? So on a number to number basis, the commonest cause is traumatic SAH, that is quite common, and among the SAH that is spontaneous origin, that is aneurysmal SAH. Right? So there are other causes like atherosclerotic, mycotic, AV malformation, vasculitis, neoplasia and other uses, but most commonly we deal with traumatic and aneurysmal SAH. Aneurysmal SAH requiring more, it is more intensively we have to treat it. So risk factors, if you remember the case scenario, if you see the risk factors are diabetes, hypertension, he is also a smoker. Okay? So risk factors are, it could be genetic, it could be familial, it could be personal. So personal history, it's very clear that a smoker and alcohol intake is there. And connective tissue disorders are among the most common things. And in familial, it is known that somebody will have a known person of a relative who is having this disorder with them. And there are variable modes of inheritance if it is familial cause. So this is, risk factors are all mainly theory which we can probably revise again and again, but coming to the point of clinical significance, how to diagnose this. So he has come with, going back to the case scenario again, he has come with sudden severe headache. Okay? So sudden severe headache, nausea and vomiting, it is a little confusing unless you have a high threshold of suspicion in a person like this. Sudden severe headache anybody can face. So whether it is really SAH or somebody can have a gnawing type of a headache with some sort of a neck stiffness, some discomfort, he may not really say that I am having a headache, or his threshold for tolerating a headache may be very high. So if he has any other forms of headache that he is suffering from, then it may be lost in the confusion. Okay. So basically what is the diagnosis history wise, whether there is trauma or not, that is very straightforward. Risk factors, whether he has a family history, whether he is a smoker, that is important. Clinical features wise, thunderclap headache. Always it is described as the most severe headache that one has had ever in his life. Alright. So another thing is called as sentinel headache. Sentinel headache is something that once the bleeding has started, sometimes in some SAH patients, they can have this irritation going on for a few weeks and they can present with few number of headaches before in the few weeks before. We have dealt with this in this case. And also associated with vomiting, loss of consciousness, neck stiffness and photophobia. So many times it is very easy to confuse headache, some alteration in sensorium, neck stiffness and photophobia to meningitis. So we should have a high index of suspicion to actually tilt our diagnosis and attention to suspect a SAH. We can always go ahead and think it is a meningitis, but it is very important that neck stiffness and photophobia are like underrated problems that we can see in SAH, but it is very quite common. Okay. So when we have made the diagnosis and we go ahead with investigation, the first investigation that we want to order is a non-contrast CT of the head. And it is one of the most sensitive tests that we have, and we will go covering one by one. So other thing, once we have done the non-contrast CT and we have gone ahead and confirmed the SAH, CT angiography will be able to, it will help us to sort of point out and where the site is, how big the aneurysm is. DSA is the gold standard of diagnosing aneurysmal SAH and SAH as such. Lumbar puncture, if all the other things are not really pointing out, a lumbar puncture is done, but that is something that, comparing to what imaging facilities we have, lumbar puncture is not really taken as, it's not so common probably. And of course, there are other investigations to cover the organs of sympathetic overactivity like the heart. So troponin and ECG is one of the common things that we order as a routine also. So coming to the first one, non-contrast CT of the head. So here I just want to point out that the brain has a lot of cisterns. There is CSF being produced in the brain. So when the CSF is produced in the brain, it is going around the brain and it's got a lot of pockets of accumulation wherever there is a subarachnoid space. So there are so many cisterns, okay, but there are some bigger ones and common ones. So this cisterna cerebellomedullaris is called as the cisterna magna also. This is one of the bigger ones. Cisterna pontis, the pontine cistern, the interpeduncular cistern. So there, so on and so forth. There are so many where the blood can get accumulated, because if the vessel gets ruptured there, the blood can get accumulated there and it can irritate the corresponding structures that is present in the brain. Okay. So here, non-contrast CT, it is the mainstay of diagnosis. Alright. So always remember that in the first 6 to 12 hours, up to nearly 24 hours, sensitivity is more than 99%. In the first 6 to 12 hours, it's almost 100%. Sensitivity remains high for at least initial 3 days. Then after that it decreases significantly. So what we find in the non-contrast CT is that there is a high attenuating amorphous substance that fills the normally dark. Always CSF field spots are dark in the CT. Okay, that it will be filled up with dense material. Okay. So this is the subarachnoid hemorrhage, which probably it takes time, but over a period of time, if you keep seeing subarachnoid hemorrhage, it is easy to pick up, because otherwise as a young, when we are training and we are beginning to see SAH, it might be easy to miss this, but over a period of time we can always pick it up very easily. So this is showing the blood in the supracellular cistern. This is showing the blood in the ambient cistern. Ambient cistern is nothing but it is the connecting part between the interpeduncular and the pontine cisterns. And the fourth ventricle, of course, it is one of the places where the CSF is already there, and here the blood is being shown in the Sylvian cistern as well. So here, just to revise our thoughts on SAH and the NCCT that we are there. So what is a large SAH? This figure number 8, I hope it is clear. It is showing a very large SAH, dilatation of the temporal halls and so are also seen. It is showing early hydrocephalus. This is one of the poor grades of SAH that we colloquially call it as a good grade and a poor grade. Okay. So there are, in figure B you can see this is a small SAH, very easy to miss. Sometimes it takes a lot of attention and index of suspicion to not miss this. Very mesencephalic SAH along with the solid arrows. This is the back side. Now if somebody has seen press, it can sort of look like press on the CT, but it actually is an SAH. It is taking, it takes some training to recognize that. And this is convectional SAH. We can see this sometimes. If you have seen traumatic brain injury, you might have seen this kind of picture many times. So coming to the NCCT, once we have done the CT, so apart from this, we have also the scoring systems that will help us to sort of identify and grade and plan our clinical management, and also give a possible prediction on the outcomes as such. Okay. So the most common grading that is recommended by all the societies, as well as it is taken to predict outcomes very well, is our WFNS grading, the Hunt and Hess grading scale, and Glasgow Coma scale. This is very important to assess the neurological status. So here if you see the WFNS grading, there is grade 1, 2, 3, 4 and 5. So Hunt and Hess also grade 1, 2, 3, 4 and 5. This is based on clinical symptoms of neurological signs and symptoms that we are actually grading, and it is always to point out what is the survival rate and outcomes. So this has been regularly used, and ASA, it has been continuously recommending the use of the scales to actually quantify your survival rates, and also helping planning out your management. And also, when you see that there is a clinical grading, that there is focal deficit or there is no focal deficit, so as we go up the grade, the focal deficits or the general deficits are more and more. So suppose here there is more deficit, always when the scale is high and clinical symptoms are not matching compared to Glasgow Coma scale, if there is a motor deficit, that will be given the higher weightage. So focal neurological deficits will be given a higher weightage compared to just the GCS as such. Please remember this, it can be asked in the practicals also. So apart from this, what is the importance of the thickness of the SAH? Sometimes it may make a difference, right? So you can see a thin SAH, thick SAH. So it is being scale graded by our Fisher and modified Fisher scaling. So initially they just named it as focal thin, diffuse thin, thick SAH, diffuse SAH. Okay, focal thin is less than 1 mm. So that's what they mean. It is less than 1 mm. Diffuse thin is just around 1 mm. thick SAH anything more than 1 mm and more than that will be graded like this. The modified Fisher scale also involves interventricular hemorrhage. So as a commonsensical observation, it is that the thickness of SAH, suppose it is very thick, it only says that there is more blood in the cisterns, there is more blood in the subarachnoid space, where of course all the pathophysiology being the blood being in that space will cause a lot of problems. Okay, especially the vasospasm is one of the most important problems. So we have to pay attention to the Fisher grading, because if the thickness is more, the chance of vasospasm and subsequent problems with delayed cerebral ischemia and all is higher. Alright, so we can always see here. So as the grade goes up, we see there is more and more chances of vasospasm here. Okay. So apart from this NCCT, suppose we are not able to find, there is a high index of suspicion, you have suspected, you have done an NCCT, but still there is no SAH, then we do a lumbar puncture, where it is done only when the CT is negative, but there is still a strong suspicion of SAH despite CT being negative, and patient presenting later than 24 hours. Sometimes the sensitivity may come down, and sometimes if there is a resource constraint where the CT is not available, then we might have to resort to this. So hallmarks are, when we do the LP, lumbar puncture, there is an elevated opening pressure, again mimicking meningitis. You should be very careful in sort of quantifying that. And there is elevated RBC count that does not diminish from tube to tube. I mean, I've not known people doing many tubes of things where the basic premise is that they take CSF in many tubes. Okay. So suppose if it is a traumatic puncture, initially the tubes will be filled with RBC, later it won't be that. That is the premise of doing this. If it is an SAH, consistently in all the tubes there will be blood. Okay. I'm not sure how many of you have actually done that. Still, if it is being done, I'm not sure. But this is the premise of doing the lumbar puncture, and it's very unreliable when there is a traumatic tap. Okay. And also, when we are seeing and examining the lumbar puncture study, xanthochromia is one of the important stuffs that can actually point out to SAH. So what is xanthochromia? So basically, when we see with normal CSF and SAH CSF, we can make out there is a difference. So this is caused by hemoglobin degradation products in the CSF. Okay. So blood is present in the CSF for at least 2 hours. It's very important that usually it develops over 6 to 12 hours. Blood should be present for at least 2 hours for the breakdown to happen. And it lasts for 2 weeks or more. Many times if they come late and the sensitivity of CAT is not there, then it can actually last 2 weeks or more. We can pick it up. So other conditions that can produce xanthochromia are elevated CSF protein that can cause color to be changed, systemic hyperbilirubinemia, this is an important thing that we should keep in mind. Traumatic lumbar puncture also, if the RBC is very high, then it is again problematic. Okay, apart from this, there is another imaging called MR angiography, which sensitivity and specificity is not as high as CT, and it is only covering medium and large aneurysms. Sensitivity is very less. So coming to the gold standard of our investigations, that is digital subtraction angiography. So here we detect the intracranial aneurysm and define the anatomical features also. So here you can see there is a huge aneurysm that is there, and that has been actually come down, and what this B feature shows is vasospasm. If you can see this and if you can see this is the internal carotid artery. Here you can see the vasospasm. So coming to the treatment of vasospasm, we will be covering it in more detail. So basic thing here is that they have done a balloon angioplasty, and once the balloon angioplasty is there is again re-establishment of some patency where the blood flow is accumulated. Okay. So coming to the etiology, most of the time there is no angiographic cause of SAH also. We'll go a bit fast. So repeat angiogram can be done in 2 weeks if the angiogram is negative. 24% of SAH patient they are found to have aneurysm on the later day. So causes for misdiagnosis is probably it is more to do with the operator himself. So ECG will come to that. So coming to the management, acute management will go a little fast here. So acute management is very important because it mainly involves covering and preventing the vasospasm. So it involves triage and initial stabilization. It also goes up with medical management. In medical management, there is BP control, what to do with antithrombotics, anticoagulants, and antifibrinotics, what we are doing, and anti-epileptics, how to titrate it. Surgical management, of course, in aneurysmal SAH, whether coiling is required or clipping is required. Embolization versus resection of AVF and complications of SAH. Okay. So acute care, it's very commonsensical. Here, the acute care is to prevent further brain injury, prevention of acute brain injury and prevent secondary brain injury. Okay, so it is also to prevent rebleeding and risk of vasospasm. The triage for any neuro patient will be same. Neuroprotective measures has to be initiated. He will be given bed rest. He will be given fever control, hyperglycemia, hypoxemia, and anemia are treated. The normothermia has to be maintained. And I have put nimodipine right here because we have to start giving it early basis and it should not be missed. It has got a huge benefit. So it is given 60 mg Q 4th hourly. Please remember, it is not 6th hourly, it's 4th hourly. It is not given 4 times a day, it's given 6 times a day. So coming to medical management, of course, we have to manage fluids. The important point here is monitor and maintain euvolemia. Don't go for hypervolemia, that is not there anymore. Euvolemia, normonatremia. Okay, hyponatremia is very common. Isotonic fluids can be used. Daily monitor hematocrit and address the dyselectrolytemia. ICP monitoring, yes, we have to do this. We have to continuously keep verifying the ICP measurement. Then we have to check for systemic factors affecting ICP sometimes, other dyselectrolytemia and metabolic factors affecting it. ICP directed management and optimization has to be done. So blood thinners, what to do here? Suppose patient is on anticoagulants, you have to stop it. If somebody is having anticoagulation and he is on the higher range of anticoagulation, we have to correct it with FFPs. And we have to institute antifibrinolytics. Here it is important to know that tranexamic acid 1 gram 6 hourly is given till up to 40 to 72 hours. Beyond 72 hours, it is not found to have a benefit. Please remember this, tranexamic acid, if you are using in SAH, it is only up to 72 hours we have to use. And DVT prophylaxis, only after aneurysm has been secured, we have to start the DVT prophylaxis. Okay, the BP control here, the most important thing is target BP is less than 160, systolic less than 160. It has been seen in many studies, though there are a lot of experts who go for 140 or 120. It is actually behaving like something like our sugar controls, where the lower pressure actually affects the CPP and it can cause risk of ischemia. So preferred drug is labetalol, and if suppose after the aneurysm is secured, if there is a hemoglobin or the perfusion is dipping, then we have to do hemodynamic augmentation. Alright. So we have to avoid hypotension after the aneurysm has been secured. It's very important to note this. Please augment hemodynamically with vasopressors. Multimodal neuromonitoring, it is very commonsensical and straightforward. It is clinical, imaging, labs, and cerebral oxygenation and blood flow. Antiepileptics, the seizure, it's usually given when there is seizure immediately after admission. The seizure usually occurs in the first 24 hours very commonly. And if there is a poor neurological grade of the SAH, then we have to start on antiepileptics. Intracranial hemorrhage, if it is there, we have to start it. And perimesencephalic bleed is there, they may require. And levetiracetam 1 gram 12th hourly is given for at least 3 days. But it is noted that between 3 days and longer stay, there is no much difference. So usually it is being given for up to 3 to 7 days. Okay. And universal prophylaxis for all SAH is equivocal. It is done on a case-to-case basis. And here important thing is that many times on a peripheral setting there is use of phenytoin in a very huge manner. We should not use it in a suspected SAH because it worsens cognitive dysfunction and poor outcomes. So surgical management, it is whether if there is an aneurysm that is detected, then whether there is a need for surgical clipping or endovascular aneurysm, that is the important thing. So that has its own pluses or minuses, we will just go there. So clipping and coiling, there are pros and cons of each. Okay, clipping is an established safe procedure since decades. It's being done, and people are experts in that. It can treat most aneurysms, including the wide-necked aneurysms. It can do it actually, and it reduces the risk of recurrence because whenever you have completely controlled the aneurysm, the recurrence rate is very less. So cons are, it's very invasive. It always needs you to admit that the patient undergoes GA, and it is sort of takes a longer recovery time and monitoring. So coiling, on the other hand, the exact cause that is there in the clipping has been addressed. It is safe at-risk patients. At-risk patients meaning they have risk factors such as smoking, diabetes, multiple comorbidities, they have old age. Those kind of patients, they are at-risk patients. It is less invasive and there is a shorter recovery time. But some aneurysms are not amenable. If it is wide neck, the coils may slip off. So if the coils will slip off, it is a problem. So it might need blood thinner therapy after that because sometimes it is known to cause flow diverters and all they might have to use. Imaging tools can be risky because when you are using a coil, they are using a lot of dyes and they are using a lot of instrumentation which can cause a lot of problems. It can have its own problems including contrast reaction and such sort of stuff. And coiling alone may not suffice in some of the cases of aneurysm, because coiling along with that there is a lot of use of fluid elevators and other devices also that may be necessary. So this is just a meta-analysis that is showing that there is a difference, and all the meta-analysis is pointing towards that coiling is a little better than clipping, but there are sometimes clipping is better, they say. So monitoring wise we have already covered it. So transcranial Doppler, the important thing to remember is that the normal blood flow velocity is less than 120. If the mean flow velocity is more than 200, or mean flow velocity is changing by more than 50 centimeters in 24 hours, that is a point where by transcranial Doppler we are able to pick up, and this is going to be a problem. We have to suspect vasospasm. Lindgard ratio is more than 6. So complications: rebleeding, vasospasm, delayed cellular ischemia. We will focus more on rebleeding and delayed cellular ischemia. So rebleeding occurs in about 20% of the SAH. This is one of the most important causes of mortality and morbidity in any of these SAH patients. So it indicates a very bad prognosis, because every time rebleeding happens, the insides of the brain are going to be sort of cooked. So prevention is the most important thing. Diagnosis, of course, new hemorrhage will be there in the CT. Just take a few minutes. So delayed cellular ischemia, this is one of the most important topics that actually we have to cover in SAH. So what happens is, the definition wise, any neurological deterioration, including focal neurological deficits and altered sensorium, which persists for more than 1 hour and cannot be explained by physiological, radiological or lab abnormalities. Okay. So here GCS dropped by more than 2 points, NIHSS score worsening by 2 points, focal neurological impairment such as this. It lasts for more than 1 hour and it is not apparent when you are actually doing aneurysm occlusion, it's not apparent, and there are no other causes. It is mostly a diagnosis of exclusion. Please remember this, it's a diagnosis of exclusion. We have to make sure that this is there. Okay, so this is the pathophysiology of how it happens. It is similar to what happens in the SAH. The key features are, it is very common between 4 to 21 days. Anywhere between 7th day it is peaking in its occurrence. So if there is any problem happening in the first week or towards the 7th day, you will be very careful about it. So vasospasm is produced by spasmogenic substances that is produced during lysis, that is very commonsensical. But there is also, sometimes the problem can happen independent of vasospasm also, that is spreading cortical depolarization and cerebral microcirculatory thrombosis also. So basically it is like this. The diagnosis, TCT, can be used to see the vasospasm. Velocity changes can be detected and picked up, and we can make sure that we are ahead of time. Treatment is hemodynamic augmentation. So here 2 things are only taken into picture: euvolemia maintenance and hemodynamic augmentation using vasopressors. And of course you are using nimodipine beforehand itself. With nimodipine we can use vasopressors. Suppose nimodipine is causing a little hypotension, we can reduce the nimodipine dose by like 50% and use it in a more frequent way. Okay. So here, after the hemodynamic augmentation, even if it is not sort of releasing the vasospasm, we have to go with endovascular therapies. Balloon angioplasty we have already seen earlier, and intra-arterial vasodilators. A lot of us might have heard intra-arterial nimodipine infusion has been given, that actually releases the spasm. Early surgical clot evacuation. This is commonsensical because we cannot leave the blood to lyse there itself. And prognosis is, case fatality rate is very high in delayed cerebral ischemia. 10% die before reaching the hospital, 25% die in about 24 hours, more than 45% die in 30 days. Okay. So hydrocephalus is communicative or obstructive. So hyponatremia is a very common thing. Seizure is, we have already discussed it in general management as such. Systemic complications, it is a result of hyperactive sympathetic and parasympathetic nervous systems. So take home is that we will have to have a high index of suspicion. Okay, and traumatic SAH being the most common, aneurysmal SAH needs intensive workup, and we have to be very careful in managing that. Okay, and among the complications, delayed cerebral ischemia is one of the important aspects that we have to diagnose, manage, and we have to make sure that it is caught early and treated early. Thank you.
Thank you, Dr.